Hello guys. Hello guys, welcome to our channel. Today we are going to discuss about the pathology, and in the pathology we are going to discuss in the two parts, and the part 1 which will be including the generally cell and cell injury, and next inflammation and also immune system, and let's see if we can complete the neoplasia or not. And other we will be having the genetics and then systems. So in the systems, mostly I will be involving this in the medicine. Okay, so the systems will be involved in the medicine. Only the few points genetics plus the system that will be included here. Okay, so this is the part 1 and this is the part 2. So those who are new to this channel, please do subscribe and watch the previous videos so that you can understand where we are already completed and which subjects we have to be focused in the next upcoming revision. So let's discuss with the first chapter, that is the cell injury. So generally the cell injury is mostly always reversible injury. Okay, sometimes only there will be irreversible injury will be seen. Okay, and what is the most common cause? The most common cause will be hypoxia. In the hypoxia, more prone is the neuron. Okay, within the minutes the neuron can damage due to hypoxia. That is one of the important point that you have to remember. And then we have the neuron. After the neuron we can see the myelin sheath. Okay, the myelin sheath, and also there will be myocytes, which will be in the hours it can go into the damage if there is a hypoxia. Let's see what is the difference from the reversible and the irreversible. The reversible injury, we all know that the reversible injury mostly there will be swelling. Why swelling? Due to hydropic, means water inside the cell, and also fats inside the cell. And this reversible injury, obviously it is going to come back after that stress. What are the stress? Hypertrophy, hyperplasia, metaplasia, and the atrophy. Hypertrophy can be physiological and also pathological. What is hypertrophy? Increase in the cell size, increase in the nucleus size, seen in the patients those who are suffering from the hypertension as a left ventricular hypertrophy, and also seen in the athletes. So athletes, those who are doing the exercise, that is seen in the athletes patients. This is a physiological and this is a pathological. Hyperplasia is increased cell number and increased the overall DNA, seen in the endometrial hyperplasia and also pregnancy patients. Metaplasia is completely, it is going to cause the one type of the cell to another type of the cell, seen in the Barrett's esophagus, and these Barrett's esophagus can increase the chance of adenocarcinoma. Atrophy is decreased cell size, decreased cell number. It can be physiological or pathological, especially seen with the aging. Irreversible injury, permanent damage to the pumps, the calcium influx will be seen, and it will increase the enzymes and calcium deposits, and these calcium deposits will cause the calcifications inside the mitochondria and irreversible damage. And under the electron microscope, that you are going to observe the amorphous fluctuant densities that will be seen. This question is asked again and again. Amorphous fluctuant densities is seen in the electron microscope of the mitochondria due to calcifications deposits. And irreversible injury is two types: apoptosis and necrosis. What is the apoptosis? Apoptosis can be physiological, such as programmed cell death. This is in the regulated manner. Necrosis is an uncontrolled accidental cell death and irreversible damage will be seen. So apoptosis need the ATP and it will show the cell shrinkage and chromatin condensation, nuclear fragmentation is seen, and under the DNA fragmentation you are going to see the step ladder pattern, and inflammation is absent because it is a physiological also, and necrosis is seen with the no ATP required, cell swelling is seen, disrupted and disrupted. It's like a bomb blast. So completely cell will be celled and that will be bursted. Nuclear will be completely disrupted and inflammation is seen, the fever, rubor, calor, dolor that will be seen in us and always pathological conditions. Let's see types of the necrosis. Coagulative, liquefatic, caseous, fat and fibrinate. Coagulative is most common overall. Second most common is the liquefatic. Coagulative necrosis is due to protein denaturation seen in all the organs except brain and also associated with the dry gangrene. These are the important points. Liquefatic is also known as a colligative and this is due to enzymatic digestion and seen in the brain and the abscess. Fungal infections, wet gangrene is seen in the one of the examples. Caseous necrosis also seen with the cheesy necrosis. Here you can see this is the cheesy necrosis seen in the TB, histoplasmosis and the coccidiomycosis. Non-caseous, what about non-caseous? Non-caseous is seen in the sarcoidosis. Fat necrosis due to trauma or the enzymatic infection and chalky white deposition. Cheesy, caseous. Chalky white, that is fatty. Okay, like fat necrosis seen in the breast injury or the omentum. And other one is the acute pancreatitis. Fibrinoid seen in the vessels. Here you can see this is the vessel and there will be depositions, right? That is fibrin deposition seen in the type 2 and 3 hypersensitivity reactions. What is apoptosis? Apoptosis is a programmed cell death and in the regulated manner, right? We discussed this is a normal also. And there will be two types. One is the initiation and other one is the execution. For the initiation, we are going to follow either the intrinsic or the extrinsic pathway. Intrinsic pathway, directly mitochondria is involved. Extrinsic pathway, like death receptors, death ligands is going to attack the cell. So instead of the whole pathway, at least remember the caspases. In the intrinsic, caspase 9 and in the extrinsic, it is a caspase 8. E for E extrinsic and E for 8. 9, how can you write the 9? Like this 9, right? Intrinsic, that is a caspase 9. For the execution, we are going to use the 3, 6, 9. 3 is most important, then the 6 and 7. Next, we also have the other types. One is the pyroptosis. Pyroptosis is seen with the IL-1. Necroptosis. What is necroptosis? The necrosis in the programmed cell death. Okay, this will be associated with the viral infections. Next one is the ferroptosis. So ferroptosis is seen with the increased ferrous levels. Next, inflammation. Inflammation is two types, right? The most commonly inflammation will be acute inflammation. Just see what is the acute versus the chronic inflammation. Okay, acute inflammation is the immediate, chronic inflammation will be the late. Here the neutrophils is involved, here the macrophages, monocytes is involved. Okay, so there will be inflammation, there will be less inflammation and this patient is having the tissue remodeling and no tissue remodeling is seen here. Let's see events. Events is also asked as a ascending descending pattern. So there will be first vascular events and then followed by the cellular events. What is the hallmark of the acute inflammation? It is going to be the vascular permeability. So the vascular permeability, which will be showing the difference of the several mediators, is going to be involved here. So if there is an injury that is present and it is going to cause this first vasodilation and then vascular permeability and stasis. Okay, first we are going to have the vasoconstriction initially. and after that it is going to followed by the vasodilation and vascular permeability. And here comes the question, what is the involved here? That is involved here is the histamine. Okay, histamine is this main one that is involved here. And next, cellular. What is the cellular? Here you can see there will be margination, rolling, adhesion, pavementing, diapedesis, chemotosis, and the phagocytosis. Here you can see this is the one cell that is going to be having the margination. Margination means coming towards the endothelial cells, and once it is endothelial it is going to roll over and there will be adhesion here, and after the adhesion the diapedesis means it is going to come near the tissue site. After coming to the tissue site there will be chemoattractants, several chemoattractants, extrinsic and the intrinsic. So these chemoattractants will increase and there will be phagocytosis and killing that particular organism. This is whole of the acute inflammation. Chronic inflammation, that is the tissue destruction, is the one of the hallmark, and for the neoplasia it is the metastasis. And what are the mediators? As I said, the histamine is one of the important, which will be increasing the vascular permeability. And what are the cells? That is the mast cells, basocells, and the platelets. And what is the stain we use? Thioridine blue. Serotonin, it is seen with the platelets and it will cause the vasoconstriction and vascular permeability. Platelet activating factor, it is also involves the platelet, endothelial cells, leukocytes, vasoconstriction, permeability, bronchoconstriction, and platelet aggregation will be seen. Nitric oxide, this is endothelium and it is coming from the arginine via envosynthase. Act via CGMP pathway. CGMP is asked a question. Arginine is asked questions. Thioridine blue is asked a question. Okay. All these are the PYTs only. Platelet aggregation is decreased. Platelet activating factor. The name itself telling activating. So there will be aggregation. Nitric oxide. It will decrease the platelet aggregation. Next, cytokines. What are the cytokines that is involved? IL-1, we all know this is for the fever. IL-4 and 6 for the anti-inflammation. IL-5 for the eosinophils. IL-8 neutrophils. 10, 13 TGF-beta anti-inflammatory. Only TGF-beta, that is for the fibrosis. And these vascular endothelial growth factors for the angiogenesis, neovascularization, interferon alpha for the acute inflammation, TNF alpha again acute inflammation, interferon gamma is for the macrophage activation. Next, what some of the immunodeficiency disorders that you should know. Immunodeficiency disorders that you have to know, such as there will be the leukocyte adhesion defect that is seen with the LAD1, and this is the autosomal recessive condition. Beta 2 integrin that is involved in this patient. Okay, and how can you know the findings? In the clinical question there will be delayed separation of the umbilical stump that is seen in this patient. LAD2, that is associated type 2, seen with the Cialis levis X modified, that is a defective, and again there will be no umbilical history in this patient. Chronic granulomatous, it is a X-linked recessive. Here itself one of the question. This will be NADPH oxidase that is a deficient, and it will cause the recurrent infections associated with the catalase positive. Catalase positive means streptococcus or the staphylococcus. And NBT, nitro blue thioridine test, is positive in negative in these patients. Cardiac Higashi, associated with the list gene defect, associated with the phagosome impairment, and there will be associated pentad. What is the pentad? 5 features. One is recurrent infections, partial albinism, thrombocytopenia, sensory neural hearing loss, and the giant granules of the neutrophils is seen. Next, immune system. In the immune system, I want you guys to know about the hypersensitivity reactions. There are the 4 types. Type 1 anaphylactic, type 2 cytotoxic, type 3 immune, type 4 is delayed. And remember by the mnemonics, such as important mnemonics for their examples. Cytotoxic is also associated with the IgE. IgE means you all know that this is associated with the allergic rhinitis or the asthma. Other than that, there will be hay fever, prostate reaction, skull stills phenomena, Cassini test. Cassini test is associated with the echinococcus. Food allergy. These are the type 1 reactions. Type 2, it is antibody mediated. In the type 2, we also have the subtype, that is the type 5. Type 5, which will be cell membrane defects. So type 2 cytotoxic or the antibody mediated, such as the myasthenia gravis, blood transfusion reactions, Goodpasture syndrome, Graves disease, immune hemolytic, immune thrombocytic purpura, Rh positive, and rheumatic heart disease, pemphigus vulgaris, pernicious anemia. These all are the examples of the cytotoxic antibody mediated. Type 3, immune complexes. Here antibody, antigen both are involved. So for this we have the SLE, serum sickness, Henon-splenic purpura, arthritis reaction, reactive arthritis, rheumatoid arthritis, PSGN, and type lepra type 2 reaction. Delayed, which will be associated with the T cell type. So delayed will be tuberculin test, Montauk's test, multiple sclerosis, and lepra type 1, contact dermatitis, and type 1 diabetes mellitus. How can you remember the lepra? Lepra reactions will follow the rule of 5, 5 rule. So type 1, if you add how much, there will be 5, 4. So type 4 hypersensitivity reaction. Lepra 5 rule again. Type 2 lepra reaction. If you want to add 3 hypersensitivity reaction, right? This is the one of the important question. Next, transplant pathology. The most commonly the transplant that we are going to use commonly is the autograft only, most commonly. Same individual. Like if you have the injury, skin injury, we are going to get from the other, right? Epidermal splint that we are going to get. Isograft, genetically identical twins. Allograft, from the different individuals. Xenograft is a different species. Next, moving on to the neoplasians. Neoplasia, they already discussed. The most importantly, the hallmark is the epistasis, right? They are the types. One is the metaplasia, and there will be dysplasia and also anaplasia, right? All this will be going to transformed as a neoplasia. And cancer epidemiology, the most common overall is the lung cancer, and in the males also the most common. These are the worldwide, these are the worldwide statistics. Next, in India, when it is comes to the India, the most common overall in the male and the female, that is the breast. In the males, that is the oral cancer, and in the females, it is the breast cancer. Leading cause of the cancer related death worldwide associated with the lung cancer. Why lung cancer is associated? Because it will include the paraneoplastic syndromes, hypercalcemia, SIADH, and tumors that is seen with the lung cancers. And skin cancers, most commonly the basal cell carcinoma is most common overall. And the important thing about the basal cell carcinoma is it does not have the metastasis. Okay, metastasis is absent in the basal cell carcinoma. In children, the most common is the leukemia, CNS tumor, and the neuroblastoma. We have to know about the cell cycle before we move on to the what are the important points. So cell cycle will be 4 phases: Z0, Z1, and S point, and the Z2 and M point. So don't have to know all the points, at least know that where are the checkpoints. So the checkpoints will be seen with the G1. Okay, G1 there is a checkpoint, and also the next checkpoints is the G2. Okay, these are the checkpoints that we are going to see. And next, P53, this is the P53, P21 that will be maintaining these checkpoints. If any cell is compromised and carrying here, this P53 will kill this cell. That is what the P53 is going to maintain. If there is a mutation, it will repair. If cannot repair, it will go into the apoptosis physiologically. If there is no mutation, the cell cycle will be continuous. And next, radio resistance versus the radio sensitive. This question is also has been asking again and again. And the radio resistance will be seen in the G1 to S phase, and radio sensitive is seen with the G1 to G2 to M phase. And what is the cell that is involved? Most commonly platelet is very resistant, nervous tissue, and vagina. Very sensitive is the lymphocyte, bone marrow, and the gonads. Oncogenes: RAS K for the colon cancer, RAS H for the renal cell cancer and the pituitary cancer, RAS-N for the melanoma, ABL is for the CML, BRAF gene is for the HCL, MYC is for the Burkitt's lymphoma, MYC-N is for the neuroblastoma, MYC-L is for the lung cancer, cyclin D, mantle cell, PDGF, osteocytoma, FGF is the fibrosarcoma, osteosarcoma, HGF is for the HCC hepatocellular carcinoma, PDGFR is for the glioma, EGFR is for the adenocarcinoma of the lungs. So there are the many easy colon cancer, C and C for the colon cancer, and N and M melanoma, ABL and CML, and BRA MYC-C and Burkitt's lymphoma BC, and NN that is for the neuroblastoma, cyclin is the mantle zone, and HGF and the HCC. These are the easy to remember and very important tables also. EGFR2 is for the breast cancer, and red gene is for the men's syndrome. KIT for the GIST, AML, melanoma and seminoma. This question has been asked. ALK is for the adenocarcinoma of the lungs. CDK4 is for the glioblastoma. And tumor suppressor gene P53, this is going to cause a Leaf-Remy syndrome. What is the Leaf-Remy syndrome? Multiple organ tumors will be seen. RB gene 13q retinoblastoma and also osteosarcoma and also pineloblastoma. NF1 that is for the neuroblastoma, NF2 is for the schwannoma. BRCA1 breast cancer, BRCA2 is for the breast cancer and also ovarian cancer. BRCA2. WT1 or W2 is for the Wilms tumor, VHL von Hippel-Lindau syndrome that is for the renal cell carcinoma. Tumor markers, calcitonin is for the multiple medullary carcinoma tumor, okay, whatever the papillary or the follicular. For this too we are going to use the thyroglobulin. Next, AFP alpha fetoprotein for the yolk sac tumor and the hepatocellular carcinoma, beta HCG germ cell tumor and also choriocarcinoma. PSA prostate cancer, catecholamines, pheochromocytoma, CA is for the colon cancer, CA72 stomach, CA19 colon and the pancreatic, CA15 breast and CA125 is the ovarian cancer. And next, carcinogens, aflatoxins, aspergillus for the hepatocellular carcinoma and benzidines for the bladder, and ionizing radiation, leukemia, papillary thyroid cancer, nickel, chromium, beryllium, silica and the radon for the lung cancer, arsenic is for the vinyl chloride, hepatic angiosarcoma. And asbestosis is two types, most common and most specific. Most specific will be mesothelioma and most common is the bronchogenic cancer. Okay, these are the important points that we have, very short synopsis that we have revised only for the important PYTs, rather than remaining all the topics that you have to revise, but at least read these important tables and the topics. Those who are new to this channel, please do subscribe, and soon we are going to have in the May and June we are going to have the we are going to have the all the rapid revision and also SVT that we are going to have in the upcoming program. Okay, so until then, please do subscribe and stay tuned, and those who are too new this, please share with your friends also, and happy preparation and see you guys again.